Hi guys, this is Dr. John Knight. I'm a physical therapist with Altius Physical Therapy and Wellness here in Eagle, and we also have a location in Avon as well. Today we're going to be talking about sciatica, what it is, what causes it, how to treat it, and some common questions at the end here. Okay, so let's get into it. So first off, what is sciatica? The term refers to more so the symptom presentation rather than the actual root cause. So this is kind of an umbrella term that is defined as low back pain that then radiates down into the legs as well. Okay. It can be caused by a whole list of other things, but the symptom presentation is typically what we refer to when we use the term sciatica. Common symptoms associated with sciatica are pain that starts in the low back that then progresses down into the legs, also tingling and numbness into the legs as well. And then with more severe cases, we'll even see muscular weakness, usually in the foot. And sometimes you'll even get something like a foot drop where when you go and take a step, your toe just kind of slams down to the ground because you don't have that motor control and the strength to do so. So we're looking for things like that to help rule in and rule out sciatica. A quick note, sciatica does not equal neuropathy. These are two different pathologies and diseases. Neuropathy is more so related to like a metabolic disease where you'll get numbness or tingling in your fingers or in your feet on both the left and right sides, whereas sciatica is more often unilateral. So one side will be worse than the other. You can get it in both sides, but usually one side is predominantly worse than the other is. So two different diseases, don't get those mixed up, okay? So let's move into what actually causes sciatica. Like I was saying, there's a whole list of things that can cause sciatica. The term, again, is just referring to the symptoms that you experience. When I talk about sciatica, I like to visualize this nerve as a big rope. So it starts in my low back, and then it goes all the way down into the legs here. Nerves do not like to be pulled or stretched. When they are, that's what usually causes the pain. So any point along this nerve pathway, if there's reduced mobility or that nerve is stuck somewhere because it doesn't have room to move, that means that the rest of the chain is getting pulled as I move and do certain, say I'm walking or bending forward to go pick something off the ground. Because I'm restricted maybe up in the glute, that causes the rest of the rope to be pulled on, and then that's when we get pain. All of these root causes have a common factor, and that is that they cause an inflammatory process in the nerves. So a disc herniation will cause an inflammatory process at the nerve root, and we'll talk about that in a second, but it'll cause that inflammatory process that then leads to less mobility for the nerve down the chain. Same with stenosis. Piriformis syndrome, on the other hand, will cause inflammation of the nerve more so in the glute because it's reducing the amount of mobility it has. So as we talk about this, we'll start in the low back and we'll talk about how the low back can change and cause limited mobility of the nerve up here, but then we'll move into the hip and we'll talk about the diagnoses there, and then we'll move all the way down the leg, okay? I'm going to go by this quick so that we don't spend like 2 hours talking about this. Starting in the low back here, this is what, if I'm looking at somebody behind them and I'm looking at their back, this is what I would see. And I've dissected out the sacrum here, so their tailbone. I've taken that away. But take a look at the purple highlights here. Each of these are nerve roots. These are little ropes that come off of your spinal cord, and then they turn into a spaghetti mess. And then those nerve roots combine together to form the actual sciatic nerve here. So it starts up here, and this one isn't highlighted. This is your L4 nerve root, and then my L5 nerve root, and then my S1, S2, S3. And L4 through S3, those nerve roots all come together to form the sciatic nerve here, okay? So let's take a closer look at the low back and what changes we can get and what will happen. So for some people, if I were to go get an MRI, some people might have what they call foraminal stenosis. This means that the area where that nerve root likes to exit, this hole or the foramen has less space, okay? And therefore that nerve root doesn't have as much mobility to move in and out of, okay? So in a healthy adult, that foramen, that hole is patent. There's a big hole and plenty of space to move. With a more degenerative spine, what we'll see is these osteophytes or more bony growth start to close that hole down a little bit. And now this nerve root has less space to move in, okay? And then again, because we're restricted in our motion up above, that causes pull and tension on the rope down below. And so then I get symptoms into my legs. When I treat foraminal stenosis conservatively as a PT, usually what we start with is some sort of flexion-based exercise, so bending forward. The reason we do that is imagine this spine. So God, I can't do that. Imagine the spine right here were to bend forward and arc this way, right? What that'll do is it will open up the holes in the back here. It will open up the space that that nerve has to exit through. So we might not be changing the actual bony growth at the foramen, but by giving this nerve some space to work with, we're reducing or mitigating the inflammatory process that's occurring at that nerve root. So treatment options for this, physical therapy, a lot of flexion-based exercises, like I just said, and then medication, some sort of anti-inflammatory medication, whether that be a steroid or an NSAID. You can get an epidural injection at the actual site where that nerve root exits. And then we'll talk about why, but surgery again is as a last resort if nothing's working for you. Okay. The next type of stenosis that we have is called central canal stenosis. So before we were looking at the spine from the side, now we're going to look at the spine from the top down. So if I had a camera on the top of my head and I was looking down through my spine, this is what I would see at each of the vertebral levels, okay? We have this big hole right behind my vertebral body. This is my spinal canal. This is where my spinal cord sits and lives in, okay? In a healthy adult, I have plenty of room. It's patent, it's open, but in a more degenerative spine, that hole that contains my spinal cord gets smaller and smaller. So now I have less room to move in here, okay? So now I have more dural tension or more tension on the rope, less mobility to move through. Just like I had talked about before, we'll probably start with flexion-based exercises here, but a lot of conservative management is focused on decreasing the inflammatory process at that segment in your spinal cord. Okay, so things like lumbar strength, abdominal strength, making sure that your movement looks good mechanically and that when you're not doing something wonky that's predisposing you to putting pressure on your dural system. Those are places to start with physical therapy, right? If conservative treatment doesn't work, because again, as a physical therapist, I can't go in and change that bony growth that's happening within the vertebral column here. So if conservative management fails, other options would be an injection, an epidural injection, or oral medication like an oral corticosteroid. And then again, as a last resort, then we can consider the surgical option. And we're gonna look at what that looks like really quick. So this is an animation of a laminectomy and likely what they would do if you chose the surgical route to manage your sciatica or your central canal stenosis. Let's play it here. Okay, so here's the spinal cord. They're gonna lie you on your stomach. You're under anesthesia, of course. And then what they're doing is they're removing the spinous process and the lamina to the side of the spinous process. And what that does is it gives the spinal cord more room to move through. If you had foraminal stenosis and that hole on the side was smaller, they would maybe they go in from the side and take a different approach. But again, same thing, they're just opening up the space for that nerve to move through. As you'll see here in a second, in order to get to this extra bony growth that might be pushing on the spinal cord, they have to actually move some of the nervous tissue away. So they're retracting part of the spinal cord there or the nerve root wherever they're doing the surgery. But by moving that really sensitive dural tissue, we're increasing our risk of getting some sort of nerve traction injury or a lesion, anything like that, which again, if we start with conservative care and we can prevent you having to go in to surgery, that's a huge benefit because then we're reducing the risk of you actually developing some sort of nerve related injury. Keep going here. And then usually what'll happen, so after they've cleaned it up a little bit, because they dissected the the spinous process here and then the transverse process as well, we have inherent instability in the lumbar spine. So usually when people get a laminectomy, they're also getting a lumbar fusion together at the same time. Okay. And again, the cons of that is that when we're fusing the lower vertebrae together, that means you can't rotate or bend or side bend or extend at that spinal level. So the benefit is that your low back doesn't hurt as much, but the cons are that now we can't move that segment of your spine at all, which means that up above, maybe my thoracic spine or my hips are going to have to compensate for that lack of motion. Okay. So less motion where the surgery was performed, resulting in some sort of compensation above and below. Okay. So that's what a laminectomy would look like. The other most common cause that we see for sciatica are disc herniations. Okay. When I talk about disc herniations, I like to imagine a jelly donut. Okay. On the outside, you've got that like nice crispy cakey, like maybe you got some cinnamon or something on there. But it's holding this jelly center in here. So the outside, the cake portion of the jelly donut, that's our discus annulus. And then on the inside here, you've got your nucleus pulposus. And this is the inside, that's the jelly there. The function of the disc here is to help absorb forces, compressive load in your spine, right? Say I go jump or something, that's a lot of compressive load on the spine. The actual disc helps to spread that force out in your low back. If the forces are too great, though, what'll end up happening is you can get something like this, where we get a protrusion or an extrusion of the actual disc. And now the jelly, because the walls of the jelly donut can't hold the jelly inside, that jelly pushes out against the walls. And in this example, the jelly is pushing on that nerve root here. Again, reducing the mobility up above, but causing symptoms and problems down below, okay? So options for treatment would be physical therapy, always start conservative, medication, again, an injection to reduce the inflammatory process actually occurring at the nerve root, and then as a last resort, surgery, okay? And the surgical option here would be a discectomy, where they actually remove the protruded portion of the disc, and then over time, the disc annulus starts to kind of heal itself back together, okay? But again, start with the conservative treatment. Okay. When we treat, so let's talk more about the physical therapy management of these things. So stenosis versus disc herniations. When I treat stenosis, I usually start with more flexion-based exercises, bending forward as opposed to extending my back. The forward bend, like you can see here, opens up this hole. So if I have foraminal stenosis, that opens up the space where that nerve exits through, and again helps to ameliorate some of that inflammatory processes that are occurring at the actual nerve root. Okay, compare that to a disc herniation. With a disc herniation, I will most likely start with extension-based exercises. The idea being that as I extend back, this increases the space at the front of my spine here, and that creates a negative vacuum and pressure that helps to pull, if I do have a prolapse here, it helps to pull some of that jelly back into the donut up front here. And then over time, as the nucleus pulposus has receded, then the annulus fibrosus on the outside will have the opportunity to kind of self-repair and heal itself over time. So stenosis versus disc herniations are treated differently. Usually, though, you'll get some sort of low back strength, core strength, and then taking a look at your movement mechanics to help spread and manage the amount of load going through your spine. So if your low back is nice and strong, instead of the joints compressing as much, similarly with movement mechanics, instead of the joints getting so much compression, the strength of the muscles will help to reduce the amount of load going through the low back instead. Okay. When I consider different treatment options for disc herniations, oftentimes it relates to the severity of the disc herniation. Okay, so if somebody has like a prolapse like this or just some degeneration, conservative treatment can oftentimes be really beneficial and help most of the time. If they have more of a severe form of disc herniations where the actual nucleus is extending out into the nerve root or the foramen, a discectomy might be more warranted because I can't go in there with my hands and change that. So the treatment options vary depending on the severity of the disc herniation that you have. Okay. Okay, so just to review, we talked about foraminal stenosis, we talked about central stenosis, and then we talked about disc herniations. I didn't dive into spondylosis, but this is a term that refers to just age-related degenerative changes in the back. And usually if you have spondylosis, you'll have one or some form of all the others above as well. So I think these are more important to pay attention to than spondylosis. But usually if you have spondylosis, you'll have some form of one of these three as well. Okay, so we're going to move on more into the hips now. So again, now we're going down the chain. So we talked about the low back. Now we're going to talk about the hips. Some things that I consider before I diagnose somebody with sciatica is looking to see if they have piriformis syndrome, trochanteric pain syndrome, or sometimes hamstring tendinopathy. So let's talk about that. So this is looking at the butt, right? I've dissected away the glute max, so the big muscle on your butt. And if we go a little deeper, we get to this muscle called the piriformis. So this relates to piriformis syndrome. As all of those nerve roots come together, then they form the sciatic nerve. That sciatic nerve travels underneath the piriformis muscle right here, in most cases, okay? The thought then being that if the piriformis muscle is really tight or my movement mechanics are putting stress and stretch on the piriformis muscle, it could be compressing the sciatic nerve, causing some of those, some tingling or pain down into the legs. So sometimes it is piriformis syndrome, and that's up to your provider to figure out. But in this case, then what we would work on is improving the movement mechanics of your hip and your low back to make sure that you're not causing undue stress on the piriformis. And then also work on some sciatic mobility as well. The funny thing with this, though, is that everybody's built different, right? Here are 6 different examples of anatomy of the sciatic nerve. So in type 1, this is your classic example here. That sciatic nerve goes underneath the piriformis, but you could have type 2, where instead this common fibular nerve, one of the branches of the sciatic nerve, actually comes through the piriformis muscle instead. Or that nerve might go on top of it, or the entire sciatic nerve might go through the piriformis muscle, or the tibial nerve might go, so there's a variety of different anatomies that can lend themselves to sciatica. And again, that's up to your provider to kind of work through. But everybody's anatomy is different, and thus everybody needs to be treated in different ways. Okay. The other thing that I had talked about was hamstring tendinopathy. Because that sciatic nerve runs right next to the hamstrings, specifically the insertion here at the ischial tuberosity, oftentimes these can be confused. So again, this is up to your provider to rule in or rule out if this is more of a hamstring tendinopathy or if it's a sciatic nerve problem. To do so, usually the PT or your provider will see if active movement and force on the hamstrings provokes pain. or if tensioning the sciatic nerve causes your symptoms. So again, that's up to your provider to decide, but sometimes sciatica can be disguised as hamstring tendinopathy as well. Go on to the next thing here. The other thing that I commonly see as a misdiagnosis for sciatica is trochanteric bursitis or trochanteric pain syndrome. Take a look at the picture on the left here. I know there's a lot going on. This is the low back. This is the left butt cheek. Okay, so I've dissected the big glute muscle over here. That big glute muscle, your glute max and your glute med and your gluteus minor, as well as the tensor fasciae lata, all of those muscles will combine together to form the IT or iliotibial band over here on the side. Okay. What sits underneath the IT band here, though, is this little circle here called your bursa. So this is a fluid-filled sac, okay? And usually you'll find these on some sort of bony prominence, but what it does is it helps to reduce the amount of friction at that bony prominence, okay? So because you have the IT band going right over it, this helps to reduce some of the friction between those structures. If all of these muscles are really tight here, or my mechanics when I walk and move lend myself to putting excessive strain and compressive forces on the bursa here, sometimes this can get inflamed and then cause hip pain. Usually this is more lateral hip pain, meaning on the side of your hip as opposed to the back. But I have had people complain of sciatic symptoms when it was really referring pain coming from the bursa here on the side. So again, this is something that can be misdiagnosed as sciatica when really it's a bursitis or some sort of trochanteric pain on the outside of the hip here. So again, that's up to your provider to figure out, but just talking about some of the other diagnoses as well. Let's move on here. Okay, so now we're going to move down. Okay, so we've talked about the hip. Now we're going to move down into the knee here. Okay, so this is that sciatic nerve. In most people, that sciatic nerve travels all the way down here, and then at the popliteal fossa over here, then it'll split. Okay, so then this nerve splits into the common fibular nerve and the tibial nerve that runs right on the back side of the knee here. So this is another example of when some sort of lack of mobility can cause pain down the leg. If for some reason my hamstrings are really tight and they're compressing on the nerve, that might cause nerve entrapment of the tibial nerve back here. Similarly, if my popliteus, which is a muscle that runs right on the backside of my knee here, is really tight, that might be pushing on the tibial nerve. If I don't have good mobility at my fibular head here where I'm circling, so this is my tibiofibular joint, if I don't have good mobility there, that might be causing compression on the common fibular nerve. So any sort of restriction related to this nerve pathway can cause symptoms down the leg as well. And then again, that's up to your provider to kind of figure out and then work through as well. Okay. But the term nerve entrapment just means that there's some sort of restriction along the nerve pathway. Okay. This can again occur even further down into the ankle. So I've treated a lot of people that have had posterior tibialis nerve pain here because they had weird mechanics when they moved that put pressure and stretch on that posterior tibial nerve over here. So any of these nerves, deep fibular nerve, saphenous nerve, which is not a branch of the sciatic nerve, but is a branch of the femoral nerve, but any of these nerves that run down through the ankle are prone to some sort of entrapment. And again, that's up to your provider to figure out, but this changes our treatment, right? Maybe now instead of we're focusing on low back stuff, now we're focused on movement mechanics, ankle strength, mobility in your ankle and your knee and stuff like that. But we have to address where any of these entrapments are actually occurring, okay? So it's important to look at the whole picture, right? The low back, the hips, that entire nerve pathway all the way down into your ankle to address any sort of entrapment or lack of mobility of the nerve, okay? And then just really quickly to review, we went over nerve entrapment. This can occur anywhere on the tibial nerve pathway, the fibular nerve pathway, and then also the sural nerve, which let me just go back here and show that really quick. That sural nerve is going to be here on the posterolateral part of your ankle. Okay, so posterior tibial nerve will be more on the inside of your ankle. Sural nerve entrapment will be on the posterolateral side of your ankle, so the back and then the outside of it. And then you can also have some common fibular nerve related pain that goes down more of the side of your ankle and your foot. Okay. Okay, so some frequent questions that I get related to sciatica. The first is, should I seek imaging first? The key word here is first. Okay, my answer is no. So when you initially start experiencing sciatic related symptoms, go see a physical therapist, because oftentimes what they can tell you will give you more information than what an image will. Oftentimes imaging can be different depending on which provider is reading it. Also, just because an image shows something, say you have spondylosis in your back, or it says like anterolithothesis of your L4 or something like that, that might not actually correlate to the symptoms that you are experiencing. You might be getting more pain in the back of your knee, and even if the L4 vertebrae is shifted slightly forward, that might not be the root cause of the problem. So MRIs will give us a bunch of information, but it has to match what you're saying as a patient, and it has to actually correlate with your symptoms. So a good place to start is just go see a physical therapist. If after a while something's not working or you're not making any progress, then you might get referred for imaging. But just routinely sending people for imaging straight off the bat is poor management of these symptoms, is costly, and can sometimes lead you down the wrong route. Okay, but imaging is good if we're not making progress and we've already tried options A and B. Okay, the second, do injections help? They do usually help, and they can provide temporary relief. Sometimes people have had injections and that just solves the problem like that, especially for more acute cases of sciatica or radiculopathy. Because there's an acute inflammatory process, having some sort of steroid injected at the nerve root or the site of pain can help to reduce the inflammatory process at that location, and then thus solve your problem, right? Sometimes they don't. Sometimes you get an injection, it lasts for like 2 weeks, and then things come right back because we haven't addressed the actual problem here. So injections are oftentimes a good band-aid. Sometimes they can provide permanent relief. But I'd start with conservative management first. Okay. Lumbar manipulation. So this is like if I go see a chiropractor or a physical therapist, they might crack your back. That's called a manipulation. So that in combination with an exercise has been shown to have significant improvements to reduce your pain and your symptoms at a month, and then also at 3 months following. But the thing is that you can't just go in and get manual therapy. You can't just go get a back massage, because that's providing you a window of pain relief, but it's not fixing and addressing the root cause, whether that be degenerative changes in your low back, poor movement mechanics, weak muscles, whatever. We need to address the root cause as opposed to just giving you a therapeutic window or therapeutic relief, right? I do use manipulations and mobilizations because it can provide a relieving window, which then we can make strength gains in. But I wouldn't advise to seeing a chiropractor once every couple of weeks just to get a manipulation, feel good for a couple of days, and then go right back to where you started, because we're not addressing that root issue. So it has to be done in combination with some sort of exercise at the same time. Okay. Go ahead and screenshot this if you'd like. Here are a couple preventative exercises. I'll preface this with saying that everybody's built different, right? So these are kind of cookie cutter exercises for addressing radiculopathy and sciatica. This lumbar windmill here will work on some lumbar mobility and rotation and side to side. Cat-cow will work more on the flexion and the extension, so sagittal plane movement mechanics. The alternative is you can also do this when you're sitting down if you have a hard time getting on your knees. And then this up here, you might not be able to see this here. This is called a sciatic nerve glide. So this person is sitting down. They're going to extend their knee. I wish you'd pointed a little bit more, and then I want you to point your toe as you extend and straighten your knee, and then look up to the ceiling. So what this is doing is it's almost flossing the nerve back and forth. As I straighten my knee, that's stretching the nerve, but as I extend my neck and point my toe, that's providing relief at the same time. So it's almost like just flossing that nerve back and forth. The big thing with this is that I'm not pushing into a stretch. I don't want to feel much of a stretch at all when I do this because again, nerves don't like being pulled and yanked on, so they don't want to be stretched here. You know you're doing it right when you don't really feel much of anything at all. Okay, that's a weird one. Dead bug heel taps here, just a little bit of core and abdominal strength. And the big thing with this one too is that we're not bearing down and pushing against the pelvic floor when we're doing this, but we're sucking that tummy in, holding that contraction. And as I'm doing this heel tap, my low back should stay pretty flat on the table or on the ground where I'm working. If I lose that flat back and now I've got a big arch in my low back, that means I've lost my abdominal control. Okay. So here's a couple things to try at home just for some prevention. And that's it. Here are a couple of references, but again, if you have any questions, feel free to reach out and connect with us at any point. All right, thanks so much for watching. Take care.